Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Yes, another very interesting question, and I'm sure people, all of you together, will be able to give me all the points. Let me hear this out, guys. Causes of breathlessness 24 hours after delivery. Let me hear this. Yeah, you can answer. I'm there. Very much there. Just let me hear your causes of breathlessness 24 hours after delivery. Yes. One you can see, of course. Yes. Pulmonary embolism is okay. Amniotic fluid embolism is fine. Peripartum cardiomyopathy, yes, very important. If you've answered these three, I will pass you. Okay, in Viva, even over here. No, I'm looking forward to only these three: pulmonary embolism, amniotic fluid embolism, cardiomyopathy. If you miss peripartum cardiomyopathy, I will not pass you for this answer. You get 2 out of 5. Only for not writing down one very important. Pulmonary edema could be one. Yes, MI is one. Very good, very good. Yogini, very good. I'm impressed. Of course, you can add that. Asthma, very good. Why can't she have an asthmatic attack? She can have breathlessness, sorry. What else? Very good. I'm very impressed. Yogini, you are presenting case next. Huh? Whenever your exams are coming, I don't care. You're presenting the next case. Good. Severe anemia. Very good, Didi. Very good. As if she's already seen the slides. See, pulmonary embolism is one. Peripartum cardiomyopathy is another one. PPH, okay, maybe yes, sudden, blood loss. Amniotic fluid embolism, pulmonary edema, and pneumonia. Anemia. Here comes Yogini's answer. Anemia, right? And some pre-existing cardiac disease. Okay, great. Anaphylaxis, yes. Why can't it be? Very good. So you have your DD has surpassed my DD. You can answer yours as well, right? Great. That's the fun. That's the fun in taking class with all my students. Look at the energy. There's so many students, 51 online. How many students are there in the class? I don't know, but 40 plus students attending the class, maybe 50 now by now, but great energy. So see how many points you've even surpassed my DD. So look at this. Even if you enlist them right now for me and write on one line each, you're going to get marks, guys. Please don't waste your time in useless pursuits. There is no fun in just, like I say always to my students, why they score so good? Almost all students who've been my regular students, they score very well. They have excellent time management skills. Everybody in my class, they know that they have to write on a skeleton first. They throw the points first, and then if you get time, just, scribble down one sentence each. And you're done, you're sorted. If you remember one thing, write down that thing and start elaborating that thing, you are bound to forget the next point. Just make the skeleton. Understand that you have to finish a 5-mark question and mostly one sheet of paper. I don't know if you're getting this kind of sheet or this kind of sheet. I don't know that. But if you're getting this horizontal kind of sheet, that one sheet is sufficient. The way we used to get it. I don't know how it is right now. You get a horizontal, you get a vertical one, guys. Through your seniors, you should know this by now. Any idea, guys? Anybody? Anyone knows? Kaushik, yes, you can tell me, guys. Anyone? What kind of sheet are you getting? And then we'll talk from there. So even if it's that, this vertical sheet, you're still getting horizontal, right? So one is sufficient. One sheet, you can write down one answer. And for that, you just write down these points, which I just said. Just imagine writing down 10 points for cause of breathlessness. Even if it's a 5 or even if it's, 4 marks question, you're bound to get marks, guys. You don't know. It's all right. No problem. So pulmonary embolism, amniotic fluid embolism, postpartum hemorrhage, peripartum cardiomyopathy, pulmonary edema, pneumonia or any respiratory infection, anemia. Okay, Charu, thank you. Pre-existing cardiac disease, could be anaphylaxis, could be drug-induced. So these are different answers for breathlessness after delivery. Now the question is, how will you manage this breathlessness after delivery? So very important is to initially you have to assess the patient. Assess, whether she is just gasping for breath or she's turning blue or her oxygen saturation is going down. Any which ways you have to assess her immediately. There's no room of taking history. So quick evaluation and treatment is essential. So you immediately give her oxygen. If she's breathless, obviously she's not able to give you any history. Immediately do an IV access, monitor the vitals, do her check on her saturation level, and if it looks like a pulmonary embolism, you will have to perform a CT. So first of all, you have to stabilize the patient, right? Call for help, give her oxygen, put an IV access, immediately, promptly evaluate the case immediately, look for the oxygen saturation, and then look for a target-oriented management. If it looks like a case of pulmonary embolism, which is very easy to assess, you'll have to take this patient up for a CT angiography, and you have to start her on anticoagulation. If you feels like a peripartum cardiomyopathy, then perform echo. Okay, start her on diuretics, beta blockers, ACE inhibitors, and anticoagulation. Right? If she looks like a case of PPH, which is very obvious, start blood transfusion, give her uterotonic agents. If she looks like a case of amniotic fluid embolism, well, then the God is with you, because there is no way in which you can do anything. You have to just give her supportive care, because immediately transfer to the ICU, give her hemodynamic support like vasopressors, and give blood products. And by the time, I don't know what will happen to the patient, but yes, that's the way you will help her out. Hemodynamic support, vasopressors, blood products, ICU care. Pulmonary edema, we just studied. Diuretics, fluid restriction. You're giving her diuretics and you're also giving her fluid restriction, and that's going to manage most of the cases. Infections, obviously antibiotics, anemia, iron therapy, blood transfusion, and if there are pre-existing cardiac conditions, ECG, echo, involvement of cardiac faculty, tailoring the management, and managing it with the beta blockers, diuretics, and anticoagulation. Mostly if there are cardiac disease, you have to manage her with beta blockers, diuretics, anticoagulation. Mostly not even anticoagulation, but at least beta blockers and diuretics are usually needed, right? And oxygen, of course, the oxygen support. How will you manage just peripartum cardiomyopathy? Now that's the question. Since that is the question, I will be specific in answering in terms of proper history, investigations, and pharmacological management. And when I talk about pharmacological management, I mean to talk about the entire split of the dosage and the agents, guys. Okay, so peripartum cardiomyopathy is managed similarly to heart failure. Okay, it's got reduced ejection fraction, so you have to involve the multidisciplinary team. You have to involve, and you have to take a quick history. Since when is she having this problem? How is she currently, feeling? Is she having any pain? Did she have any, chest pain radiating to back? Was she having a previously known cardiac disease disorders which we don't know of? Is she having pain anywhere else? Is it radiating to the left arm? Was it, is it a constricting type? Or is it, is she also having palpitations? Did she faint? These kind of questions we're going to ask her. Pharmacological management, you have to give her furosemide. And of course, after doing an ECG, echo, involving the cardiologist, then we give her the pharmacological management, in which we give diuretics, beta blockers, ACE inhibitors. Guys, please don't make me read the dose also to you. Just read it out yourself. These are the pharmacological management. Anticoagulation. And if it's, we're talking about a non-pharmacological management, then you have to restrict the sodium. You have to restrict the fluid, because here you're having a cardiomyopathy. Remember, when I'm talking about cardiomyopathy, that means the muscles are flailing. They're not able to pump properly. So to pump properly, you might even require digoxin, digitalis, something like that, as I don't know, they've not written it down over here. You might require the these agents which are responsible for increasing the contractility of the heart. They might be required as well, because right now, for whatever reason, the heart muscles are not pumping properly. So in that case, we need to involve, of course, the cardiac team, and we need to put her on diuretics, beta blockers, and ACE inhibitors. Obviously, ACE inhibitors is against the increased blood pressure, if at all. We do not want to increase the workload on the heart. So you decrease the preload, you would also decrease the afterload. These are being taken from the AHA guidelines, again, from RCOG guidelines, and from the European Society of Cardiology. Correct? Yeah. Now, this is a question which is based on the complete GTG guideline on the antenatal corticosteroid. What is the role? Well, it reduces the respiratory distress syndrome, number one. It reduces the neonatal morbidity and mortality if given between 24 and 34 weeks. It prevents the IVH, intraventricular hemorrhage, necrotizing enterocolitis, and neurodevelopmental outcomes. It helps in that. So all the primary benefits of the antenatal corticosteroids are seen in terms of survival and reduction of morbidity. There is some evidence that suggests antenatal steroid administration can have long-term neurodevelopmental benefits. Some of them, they say that the corticosteroids cause low IQ, okay, in the long run. Some, they say they have some neurological benefits which have not been totally balanced against the odds of giving them towards the end or a repeat dose. Otherwise, with respect to the steroids given towards the end or a repeat dose, correct? So we are not going to mention this neurodevelopmental outcome, but we're going to definitely talk about decreasing the respiratory distress syndrome, decreasing neonatal morbidity, and decreasing intraventricular hemorrhage, which is written in GTG. Okay. Then they asked about drug dosage recommendations. Here are the dosages, which you might by now you should be well versed with, and these are the recommendations. Actually, it is recommended between 24-34 weeks, but it can also be given between 34 to 37 weeks. Okay. Specifically with women with PPROM, they are recommended in the presence of PPROM as risk to neonatal morbidity from prematurity outweighs the risk. And PPROM, you should take it till 37 weeks if the conditions allow, but just in case she goes into labor, she should be having a dose of corticosteroids. On all the other conditions like planning a preterm cesarean section, multiple pregnancies, all these conditions you should give preterm labor, you should give corticosteroids. Oh my god, I have some capacity to write down so much. Anyways, so mostly your answer has been covered by these 4 slides, and nothing will go out of this, right? So please just mention and remember that they have been written down by the GTG guidelines, and everything that was there in the GTG guidelines has been included in the slide, and this is solely and exclusively made from the guideline on antenatal corticosteroids. Now, there was a question that came on Bishop score, and here's the Bishop score for you. This is the table, that's all you need to know. Then there was a question that was asked on drugs of induction of labor, the indications, this is the table, contraindications, this is the column, dosage, here's the column, and here's the side effect. Okay, made from anybody? From the FOXI. Okay, I have not taken in any international guidelines for this. FOXI guidelines, the induction of labor is a chapter on it. One of my mentors was one of the editors of that, so I have written down and I've included her notes. Now, last question, thankfully. My students are tired, and so am I. Let's start. 38 weeks with loss of fetal movements. 38 weeks with loss of fetal movements. 10 stand abdomen. I was stopping at loss of fetal movements because there's a case that I've taken on that. 10 stand abdomen, dark colored blood per vagina. So this looks like a case of abruptio, isn't it? It could be uterine rupture as well. So first of all, we'll talk about the differential diagnosis. That looks like a case of placental abruption, but can be uterine rupture, and it can be vasa previa, right? And it could be just simply intrauterine fetal demise. So everything I've described, and I've given you the signs and symptoms, and risk factors you can skip. There's nothing so important about the risk factor. How will you manage this case? So very important quick history examination. Any recent trauma, asking for any uterine contractions. Okay. Then you go for a complete fetal monitoring with the help of a CTG and ultrasound, because she's talking about decreased fetal. Very important for us is to establish if the baby is dead or alive. For an alive baby, we'll do anything possible to safeguard the baby. But if the baby is already dead, then we have a choice of giving her induction of labor if the patient is hemodynamically stable, isn't it? She is leaking blood, but she's hemodynamically stable. She can go ahead and take a normal labor, at least for a dead baby. Now, ultrasound, of course, to confirm the fetal status, placental clots, placental location. Yeah, what if it's a placenta previa? How will you then give her a chance? Okay, then look for a CBC, coagulation profile, blood cross match, give a Betke test if it's required, and then proceed. What was asked, by the way? Oh, I think management chances are less. I think differential diagnosis and workup is asked, right? Okay. Okay, differential diagnosis and management of the above case was the first question. And here is the management of this case. So wait a second. I'll just write down the management. This part is the management. Right. So how will you manage a case with placental abruption? You will manage it with you'll stabilize this patient with the help of air breathing circulation. Try to immediately deliver the baby, because here the patient having proper placental abruption any time, it can involve that much of placenta that the baby might be compromised. So you need to deliver this baby. Okay. If the fetus is alive, an emergency cesarean section is usually indicated. If the fetus has already demised, the mother is stable, and vaginal delivery will be considered, which I told you. If it's a uterine rupture, well, emergency surgery is recommended, immediate laparotomy and the delivery of the baby. Repair of the uterus. See, if it's a uterine rupture, you'll have to open up, right? Maternal resuscitation with the help of aggressive fluid resuscitation, blood transfusion if required, and monitoring for shock and DIC. Very important. Vaza previa, no, you have to do cesarean, because here the baby is at risk, So immediate delivery is essential. Otherwise, a fetus will come exsanguinated completely. And if it's an intrauterine fetal demise, well, in that case, you'll have to provide psychological support, emotional support, counseling, induction of labor for the delivery of the baby, cancer oxytocin, prostaglandins, depending on the wishes. And I think with this, I finished the class. Sorry for overshooting the time. I tried my best to finish off in 1.5 hours. Really sorry. And here, I think I've taken it from the FOXY guidelines. Clinical recommendations. So, thank you so much, guys, for being alert and awake till last. I'm sorry for keeping you awake for so long. Thank you for giving me this 1 hour, but this, 1.5 hour that you spend with me, it goes fast. You start to remember, you are active, you are alert, you answer in the class, and usually this is the best management of this 1.5 hour, which is why I urge everyone to attend the live class. It's far more, better than sitting alone and studying. I have tried that, okay? I've been a student recently, so for my fellowships and everything, it's horrible to sit and study alone. It's fun to sit with the class. It looks like you gives a small class-like feel. Everyone is there, everyone is alert, and everyone is, attentive. So thank you so much, guys. Thank you, all my lovely students, Yogini, Kaushik, Charu, Salma, especially my favorite Usha, and who all were there in the class. Let me, Salma, yes, you were excellent. Lavanya, thank you so much for being, the strength of my class, the fire in the class. So thank you, and good night. God bless everyone. I hope to see you tomorrow. There's a class on hypothyroidism in pregnancy. Please attend that, because it's going to be most probably an hour class or so, because there's not much to discuss, but it will be a fun class. Why? Because hypothyroidism, fortunately or unfortunately, is associated with all your cases in the exam. You can't, ignore it, and you can't even add it, because you can have a Viva on that. So just for that sake, we have taken a case on hypothyroidism in pregnancy. Shreya has been, my favorite student amongst so many of you. She's one of my favorites who's taken up that case, and she's ready to present. And hopefully we'll be coming up with who's taking up molar pregnancy. Charu, are you there? You taking up? Please do take it, and let's present it the next Saturday. So yeah, I hope to see you tomorrow at 4 for the class, and then we'll take up the next May paper 3, and then following up maybe another class on case discussion. So guys, thank you so much. God bless, and I take your leave. All right. Yes, thank you so much for attending the class, and I take your leave, everyone. Thank you, and God bless.